запиті, а доповідь буде на тему «Нетипове ехокардіографічне зображення як вступ до правильного діагнозу».
Thank you very much for introduction. I will try to shorten my speech. I'm Wiktoria Wojciechowska from Kraków, Poland. I'm working at the first cardiology department, Jagiellonian University, Kraków, Poland. What I'm going to say, I'm a cardiologist, so I'm going to say that the radiologists are strongly needed in our daily practice. I will present the case of a middle-aged woman. She was admitted to the laryngology department for further diagnosis of painless exophthalmos. And biopsy at the time of the tumor was planned. However, our anesthesiologist asked strongly for cardiovascular evaluation. Why? Because she complained of chest pain. It was not typical chest pain for ischemia, but echocardiography and cardiac evaluation was asked. That's why she arrived to our department for further diagnosis. She was in a good condition. However, the xanthelasma at her eyelids was very pronounced. Among other symptoms and signs which she presented, her history included arterial hypertension and, what is surprisingly, 4-year history of diabetes insipidus. He also complained of bone pain. It wasn't very severe pain, however, it was persistent pain. And she also mentioned that she was treated because some thyroid gland problem. And she mentioned that during ultrasonography of the neck of the thyroid gland, the jugular vein, deep jugular vein was, jugular vein thrombosis was seen. So starting our cardiovascular evaluation, we obviously started with ECG, and there were any sign of ischemia or left ventricle hypertrophy besides of this history of chest pain and also this history of hypertension disease. But starting echocardiography, we revealed from the first sight several pathological findings. First of all, we cannot miss this peripheral effusion, pretty large peripheral effusion. Relying to the previous speech, we can say that it's certainly chronic process, otherwise she will present it with tamponade. She was in a good condition, as I mentioned at the beginning, so it's definitely chronic process. So we have a lot of fluid behind the posterior wall and a lot of fluid before right ventricle. We can also distinguish the left ventricle dilation and diminishing of ejection fraction, at least mild diminution of ejection fraction, and also mild mitral regurgitation. Moving on to 4-chamber view projection, we can also see some pericardial effusion with partial collapsing of the right atrium. We can distinguish the fluid at the lateral wall, diminished ejection fraction, which was already seen in the previous projection. But look at the region where we usually expecting distending aorta in the 4-chamber view echocardiography. We can distinguish some additional echo, irregular in their shape, with some flow inside of it. We can presume that it's aorta, but its wall, changed for some reason. When we move transducer anti-clockwise, we can see 2-chamber view. At this projection, it's a little bit modified to properly visualize longitudinally aorta, descending aorta. What we have here, we really have aorta, but look at the wall of the aorta. It's really thickened and hyper-echogenic. So we have at least one pathological findings by one projection. Finishing the examination, we should check, obviously, when we have pericardial effusion, vena cava inferior, it was not dilated, it was probably collapsed during inspiration-expiration action. But this projection disappointed us. Look at this atrioventricular sulcus. We have additional echo here also. So, taking into account all previous history and findings from echocardiography, the decision was that we rather have some kind of systemic disease, not a one problem, but one big problem, so that we recommend to diagnose further patient as a whole patient, not locally by biopsy of exophthalmos. That's why she was transported to our to other department, to Department of Allergy and Immunology, where after CT of chest and MRI of chest and heart, after suggestion, strong suggestion of radiologists, clinicians make the final diagnosis. What was the diagnosis? Erdheim-Chester disease. This is a very rare disease which was described by two pathologists, Erdheim and Chester, in 1930. This disease is really rare. At this moment, we have in literature about 400 cases worldwide. Look at the slide. What is the disease is? This is pathological infiltration, mainly by histiocyte and giant cells and lipid-laden macrophages. What is typical for this disease is generalized sclerosis of long bones. And as it was in our case, it's usually the onset in a middle-aged. Bone are mostly involved organ in this disease. Sclerosis is usually symmetrical, and bone pain is very typical symptom. As I mentioned, it's not severe, but it's persistent. More than 50% of these patients have some kind of extraskeletal symptoms. Among them, the most common is retroperitoneal fibrosis, and those symptoms which was also present in our case, it was diabetes insipidus, exophthalmos in those xanthomas which was visible in the first sight in patient. Also, neurological signs, dyspnea due to pleural effusion could be also possible, kidney failure and liver failure. Our findings, which was absolutely further explored, which was seen in echocardiography, is involvement of aorta. It's common situation that aorta is involved in the disease. What we saw in echocardiography, it is precisely visible in computer tomography of a chest, where we have periaortic infiltration, which cause narrowing, some region narrowing of the aorta lumen. In our patient, it was less than 13 millimeters in diameter narrowing of the aorta. So we can say that we some kind of coated aorta. What about heart? What we saw in the heart? So cardiovascular involvement in this disease reach even 75% of those patients. However, it's commonly asymptomatic, but please remember this life-threatening complication of this involvement is very common. That's why we should precisely evaluate those patient cardiovascularly. What I mean, first of all, the infiltration may be in the pericardium. That's why we had this pericardial effusion. While infiltration of the myocardium shows some predilection to the right ventricle. This is the main region where this infiltration, or let's say pseudotumor, appears between atria and ventricle, somewhere in the atria-ventricle sulcus, and it may cause collapsing or narrowing of right atrium, right coronary artery. That's why ischemia signs, VT, life-threatening VT, may also appear. So it's a very typical location which was seen in our patient also. Taking into account the systemic, that this disease, Erdheim-Chester disease, is the systemic disease, obviously the treatment is also systemic. She was treated with immunosuppression and high dose of glucocorticosteroids. The reasonable question is, what is the prognosis in this disease? According to recent literature, we have information that it's rather pure prognosis. However, newly developed treatment, I mean introduction, the interferon therapy, costs about 68% of 5 years follow-up. So my main information from this case is that the ultrasonography, echocardiography, it's rather too small to open the door to make a proper diagnosis, but it can precisely point it out the door which should be opened, precisely to show which further modalities, more advanced modalities, could be involved to proper diagnosis. Thank you very much. I hope I was short enough.